So my name is Vanessa Grubin, and I'm delighted to be moderating the next panel this morning. Our panelists this morning are Jason Nickerson, Jeremy DeBeer, and Katrina Plamondon, and I'm going to introduce them one by one and at the outset, and then turn the floor over to our speakers. They're going to speak for about 10 minutes, 7 to 10 minutes each. We're going to have an opportunity for them to respond to each other's comments, and then we'll open it for some Q&A afterwards. So starting us off will be Dr. Jason Nickerson, who is the humanitarian representative to Canada for Doctors Without Borders, Médecins Sans Frontières. He is a clinical scientist at the Briere Research Institute and adjunct professor of common law at the University of Ottawa's Centre for Health Law Policy and Ethics. Jason leads MSF's humanitarian diplomacy in Canada and provides advice on humanitarian operations, medical advocacy, and policy. His research is published in numerous high-impact medical journals, and he's widely quoted in international news outlets on various global health issues, including COVID-19, humanitarian assistance in natural disasters, and disease epidemics such as Ebola. Our second speaker is Jeremy DeBeer, who is a professor here at the Faculty of Common Law at the University of Ottawa. Professor DeBeer is a globally recognized researcher in the fields of intellectual property and open collaborative innovation. His contributions to Canadian intellectual property legislation, court decisions, and public policies have played a pivotal role in solving practical challenges related to innovation in the digital economy, life science industries, and the clean technology sector. Professor DeBeer serves as co-director of Open Air, which he co-founded in 2004. And his expertise is regularly relied on by a range of UN agencies, international organizations, and governments worldwide. And then our final speaker this morning will be Katrina Plamondon, who is a registered nurse, assistant professor, and the Michael Smith Health Research BC Scholar at the School of Nursing at the University of British Columbia, Okanagan. She is an equity scholar who grounds her work in critical anti-oppressive pedagogy, relational theory, and practices. And her research focuses on critical questions about how to facilitate integration of equity-centered principles and practices across sectors and settings, equipping people to engage in practices, partnerships, policy, and society in ways that contribute to more equitable futures. So I'm going to turn it over to Dr. Nickerson to kick us off.
Great, thanks very much. Hi, everybody, nice to be here. So I'm gonna center my comments, and I'm sorry, I don't have slides, so you're just gonna have to listen to me talk. I'm gonna center my comments really around the pandemic instrument and some of the concerns and maybe opportunities, I guess, that we see coming out of the COVID-19 pandemic. And I'm going to start by saying two things. One is that MSF has been a very active participant in providing commentary and feedback into the various articles and language that's being used in the pandemic treaty. So Adam Houston, who works on my team and who some of you may know is a health law scholar, has been very active in formulating some of our analysis and our comments and so on. So we do see the importance of capitalizing, I guess, taking advantage of this moment where the world has decided to negotiate a new pandemic instrument as sort of, the next phase of trying to come to some agreement on how the world will respond to future pandemics. I will say that I'm skeptical of this exercise in many different ways. And so I'm going to offer a few comments kind of focused around three different areas that are both specific to the pandemic treaty, but also a bit broader than the pandemic treaty as well, because there's a number of different issues that are coming up and that have come up both during the COVID-19 pandemic and before, during, and after, I guess we'll say, that relates to how the world responds or does not respond to emerging infectious diseases, but also outbreaks of known infectious diseases that have serious local, regional, and global public health implications. And so issue number one is exactly this, which is, what are the kinds of health emergencies that we're actually trying to address here? So the pandemic instrument, obviously is trying to frame a global response and a set of norms and agreements around how the world responds to the global spread of pathogens and variants that are infecting humans and that overwhelm health systems and so on. And so there's sort of the initial framing of this instrument is exactly this. It's a pandemic. It's a global spread of a pathogen or a disease. One of our main comments is that this doesn't actually necessarily align with public health emergency of international concern. So first of all, there's a bit of a lack of congruence there between different international instruments and definitions. But I think that we also quite pragmatically need to recognize that, we are in this situation of we've even got the treaty up there on the wall, I guess. So we need to contend with the reality that the world continues to face outbreaks of both known and emerging infectious diseases that produce significant morbidity and mortality, have serious public health consequences, for which there's almost effectively no response. So outbreaks of things like measles that produce significant morbidity and quite significant mortality are basically unresponded to in many parts of the world. We've responded to large outbreaks of measles, for example, in Democratic Republic of Congo. In recent years, we see huge gaps in vaccination coverage for things like diphtheria. We're actually currently responding to probably the largest outbreak of diphtheria in recorded history in West Africa at the moment, affecting multiple countries. This is a serious public health event. It has real potential for implications beyond local communities, and that's not what we're talking about in a pandemic treaty. And maybe that's fine, but the reality is that these diseases are often neglected. They do not represent the sort of global health security threat to rich countries, if we're being very honest, that triggers the kind of conversations and response that I think are being characterized in the pandemic treaty. So part of my skepticism here is simply to question really what are our objectives behind all of this, and is it actually an instrument about global public health response, or is this wrapped up in the global health security kind of conversation and lens, which we have seen, of course, has neglected many of the public health concerns in the places where we work. Closely related to that is the issue of equity, and we're going to have a presentation about that. So I will just make a few comments to say that the pandemic highlighted huge equity in access issues related to medical countermeasures, so vaccines, diagnostic tests, therapeutics, and so on. And I think that we really need to temper our expectations for what a pandemic accord can meaningfully achieve to address some of the underlying problems here, simply because so much of the access and equity issues related to things like vaccines, therapeutics, and so on, they're tied up in market forces, they're tied up in domestic innovation policies, they're obviously related to things like TRIPS agreements and so on. It's quite clear that countries are not particularly interested in touching a lot of these different policies and the global rules that shape things like technology transfer or intellectual property rights and so on. And so I think we should be quite concerned about the fact that we are going to leave a pandemic and establish, a new international treaty that basically leaves the rules of the game that created and allowed to perpetuate massive inequities in access more or less intact. But also related to the equity and access to medical countermeasures is the fact that we have an entire research and development system that produces these technologies that basically operates or allows for market failures to continue to exist for many of the infectious diseases that we should be concerned about when we're concerned about global pandemics. Emerging infectious diseases, quite frankly, are not very profitable until they represent a global health threat. That's simply the reality. There are multiple pathogens that are clearly recognized as pathogens with pandemic potential, things like Marburg, things like Ebola Sudan, things like Lassa fever. Lassa fever affects hundreds of thousands of people in many countries, and we have no approved vaccine for it. We have multiple vaccine candidates that are languishing on the shelf. The only approved therapeutic is ribavirin, which probably doesn't work. There are countless examples of this. And so, I'm quite skeptical that we're going to actually crack the nut of how do we develop prior to a global pandemic, the kinds of medical countermeasures that we actually need to be addressing emerging infectious diseases before we tip over into the global pandemic kind of space. And, effectively, it's too late. And we have quite a bit to say about that because this is a problem that we faced for many, many years related to things like neglected tropical diseases and so on. The third point that I'll make is that the pandemic treaty really doesn't address many of the concerns that we have as a humanitarian organization that relate to the particular vulnerabilities that people affected by humanitarian crises like armed conflicts experience. So there is an article that relates to the persons in vulnerable situations, but it really doesn't adequately address the realities of fragile and conflict-affected states, and in particular, people who live outside of areas of government control or who may not necessarily be captured by state health insurance schemes or national health coverage programs. So we saw this in particular when in 2021, we made an attempt to use the humanitarian buffer that was created by COVAX, basically to allocate vaccines in humanitarian situations. It failed on multiple accounts, in large part because COVAX was not designed to be used. COVAX being the vaccine distribution mechanism, was really not designed to be used by non-state entities. But we need to recognize that there are millions of people who are experiencing statelessness. There are millions of people who live in humanitarian crises, who are perhaps undocumented migrants, who, for whatever reason, aren't afforded the same kinds of access to a health system where a state is going to procure vaccines and deploy them to achieve vaccination coverage. And that's not addressed really in any meaningful way by the pandemic treaty. The second is quite practical, which is the reality that health workers and humanitarian workers during a global pandemic need to continue to move. We faced immense logistical challenges in trying to send cargo and trying to send medical personnel from countries to other countries because humanitarian aid workers were generally not exempted from border control measures during the pandemic, including in Canada, which actively denied our request to transit staff through Canada and actually made the process of us sending specialized medical professionals to humanitarian crises very challenging, particularly when they were coming back. So, while there is particular recognition in the pandemic treaty of persons in vulnerable situations, it's quite superficial from the perspective of a humanitarian organization and really doesn't go to the lengths that we needed to address the particularities of working in fragile and conflict-affected states. And again, this is one of the, I would say, overarching challenges of something like a pandemic instrument, which is trying to interface without modifying different aspects of international law and various treaties. The provision of medical relief inside of armed conflict is obviously covered by international humanitarian law, and that's quite complex and so on. But we're moving towards quite complex conversations, and we do have quite a bit of experience coming out of the last close to 4 years of a pandemic that should be informing the kinds of responses that we need. But I'm quite concerned, and I would say quite skeptical that we're simply not going to get a particularly ambitious kind of pandemic instrument coming out of this. So that's sort of the 3 bullet point Jason Nickerson hot take on the pandemic accord, but happy to answer your questions. Thanks.
Well, thank you very much. We do have the text of the pandemic treaty. If I saw that up a second ago, but that would be useful. I wanted to thank everyone for welcoming me into this space. I told Professor Grubin the other day that I consider myself a dabbler in health law and policy. And what I thought I'd like to do is apply some insights from my work in international intellectual property and innovation policy, acquired by working on topics in like health and agriculture and climate action and environment, to explain why the specific provisions that are now being negotiated in the pandemic accord will not solve the problem and will likely exacerbate inequity. So I wanted to also acknowledge that that the remarks today draw upon collaborative research with a team of people. A lot of what I'm about to say flows from a chapter that I recently published with Dr. Richard Gold at McGill and relates to research that I'm currently working on with Dr. Ogwamanom here at the University of Ottawa. And, my research partners, Dr. Nkube in Cape Town and Dr. Omino in Nairobi. And we have a team of students and postdocs as well. I wanted to particularly acknowledge Rosa de Coker, one of our JD students who's been working closely with our team on this issue, and one of our postdocs, Wami Kolawole, who's just about to take up a position at U of T, which is exciting. Anyways, all that to say that I'm here as a conduit for ideas from a team of researchers to talk about this, this negotiating text. And in particular, I just wanted to highlight 4 articles that are the core of our focus. And I'd like to do this because it gives some specificity to our discussion. So the articles 9 to 12 deal with R&D, sustainable production, which is really code for, well, production. It's not sure how sustainable it is. Tech transfer and access and benefit sharing. The heart of the paradox in the pandemic instrument that makes it likely to exacerbate as opposed to ameliorate inequity is in the preamble. In particular, recital 10, talking about the importance of intellectual property, but recalling that it shouldn't stop member states from taking measures to protect public health. And we know that that language has, for decades, been ineffective to deal with many of the issues that Dr. Nickerson spoke about just a second ago. At the same time as recognizing the importance of intellectual property protection, the recital underscores the importance of promoting early, safe, transparent, and rapid sharing, in particular of gene sequence data. And this paradox lies at the heart of these central provisions in the pandemic instrument. Let me bring that alive with a concrete example. Omicron was sequenced by scientists at Stellenbosch University in South Africa. First thing they did was make the gene sequence data widely available around the world. That was supposed to lead to further research and development, ideally the production of vaccines targeting that particular variant. Instead, what we saw was immediate xenophobia and travel bans as a result of providing open access to the scientific data. So the South African scientists sequenced Omicron, provided the data to the world, which in itself is a important thing to recognize to overcome the stereotype that this kind of innovation isn't happening in African countries. It very much is, as we see. But then with that open data, we have new vaccines developed by global pharmaceutical companies in the North. And it would be one thing if they were accessible at a high price to citizens of countries where the variant was sequenced in the first place, but they weren't accessible at all. And so what the pandemic accord is doing is emphasizing that when we have data, there's an obligation to share that openly and rapidly. But there's no correlative or obligation to share the benefits that come from that. Now, there are provisions on access and benefit sharing, but they're highly ineffective. What we see when we look in closer detail at the provisions on research and development, for example, is aspirational language about promoting research collaboration for access to research through open science approaches. That's the emphasis on sharing the data, sharing the scientific research and innovation. What the actual obligation is that parties shall publish the terms of government-funded R&D agreements, including information on how to access scientific publications and data repositories. Now, the scientific publications, of course, are largely copyright protected and inaccessible to scientists in the global south. Yet the data provided by those scientists needs to be open, findable, accessible, interoperable, and reusable. And the obligation is for the governments in primarily the global north to just provide information about licensing and terms. The obligation for sustainable production is merely to strengthen coordination related to public health and intellectual property and trade. But herein lies the problem. What's going on is the shift of debates out of one forum where negotiators may have a certain amount of power or momentum. The debates are then shifted to another forum where there's an imbalance of power and inequitable access to the knowledge and the resources needed to actually negotiate fair outcomes in those other forums. And we have diluted language due in part to the contributions of the Canadian government, emphasizing that there should be no mandatory obligations to waive or compulsorily license intellectual property, but rather simply encouragement from those that receive public funding to grant royalty-free licenses. Encouraging those that receive public funding to waive for a limited duration royalties. Promoting the voluntary licensing, and that's a particular Canadian innovation that Canadian negotiators have pushed for, voluntary licensing as opposed to mandatory licensing. Yet on the other hand, when we have this intellectual property and data, we're supposed to strengthen and develop innovative ways of pooling the knowledge, the intellectual property and data, but only on mutually agreed upon terms. And when it comes to any actual flexibilities, the pandemic instrument punts that to the World Trade Organization, suggesting that we should use the flexibilities of the TRIPS agreement. The reason it does that is because we know those flexibilities to be ineffective. So by shifting the forum into another space where we know there actually won't be a positive outcome, we're able to make it look like something's happening, but it's really not. In terms of particular waivers of intellectual property rights, like the TRIPS waiver, parties shall commit to agree to waivers and encourage the holders of patents to waive or manage the payment of royalties. There are two good provisions, which I think are quite vulnerable at the moment. Negotiations and the latest round of negotiations just ended on Wednesday. The mandate is to renegotiate new text by January and then hold the next meetings in February and March. With recipients of public funding, the current language suggests that recipients of public funding for the development of pandemic-related products, i.e. vaccines, shall be required to waive intellectual property royalties, not the rights, but the royalties. And a provision that suggests that when parties are engaged in bilateral or regional negotiations, that they should take steps to ensure that those new negotiated provisions don't interfere with what's in the WTO TRIPS agreement. If that stays, that's actually quite a good defensive provision, because what tends to happen is in the bilateral negotiations, any flexibilities negotiated at the multilateral level are usurped by more specific provisions, what we call TRIPS plus provisions. So these, in my view, are good provisions, but quite vulnerable. I'll end by briefly discussing this system of access and benefit sharing. The system that's being proposed for pathogens is modeled almost exactly on the system that already exists for the genomic data related to the world's staple crops. And that's administered by the Food and Agriculture Organization under an instrument called the International Treaty for Plant Genetic Resources for Food and Agriculture. The idea is that we make data related to pathogens, like we make gene sequence data related to food and agriculture, open in a repository, seed banks in the food and agriculture context, slightly different in this context. And then parties are prohibited from claiming any intellectual property rights on the materials they contribute to that system or on materials taken out of that system in unaltered form, but not from claiming intellectual property rights built on the data that's taken from that repository. And instead, what parties are supposed to do is basically negotiate or give back benefit sharing in the form of 10% of pandemic-related products as a donation and 10% at affordable prices. The system has been highly ineffective in the context of food and agriculture and is likely to be equally ineffective in the context of gene sequence data related to pathogens. Yet we're on a fast train to locking this system in. So I know that's a lot of technical information, but I hope that by diving actually into the provisions, we can see in real time how these inequities are being entrenched. I think it's really important to talk broadly about the principles. It also helps, in my view, to look at the specific provisions that are being negotiated so that hopefully we can advance these provisions in a way that are more equitable if and when this instrument takes effect. Thank you.
How close do I need to be? Can you hear me? No. Needs to be closer. Thank you. Well, I think I will, I'm in no way in disagreement with, there's not going to be a lot of controversial disagreement among the three of us, but I think I'll hopefully add a little bit in sharing both about practice principles and very specific ways we can think about integrating equity in and through a new pandemic instrument. Solidarity from Vaccine Equity research team, which Professor Habibi is part of. And you can see our other amazing team members there and our funders and good acknowledgement. So I'm a nurse. I've had a career that has spanned a lot of years as a clinical, like practicing in frontline, practicing in global public health and in health system settings. And over the last shorter period of time, last 7 or so years, more in academic settings. And I'm not a vaccine scientist. I'm an equity scholar and interested in critical population health. And so the work that we've done with the Solidarity for Vaccine Equity study really is not necessarily because any of us are vaccine scientists, but because all of us on the team have a particular interest in issues of equity and saw the issue of vaccine equity as a really important and powerful window that we could understand policy trajectories and how different decisions and ways of thinking about the world and what we could do in the context of a pandemic might do something about our collective responses. And in particular, we came together because we were very conscious of our roles as citizens of a wealthy, rich, high-income country that was behaving in a way on the global stage that was incongruent with what we thought was what the evidence suggested we should do. It was incongruent with what our ethics thought we should be doing. And these contradictions and tensions prompted us to think about how could we what could we do about understanding how Canada's contributions on the global stage advanced a particular kind of way of thinking, and how could we learn from that particular policy trajectory? So it was in that context that we started doing this work. And so here's just a little bit of a highlight, which many of you are probably well aware of, but just in case you are not, about the context and extremes of vaccine inequity over the course of the pandemic. So in October of 2021, the vast majority of the world's population still did not have access to vaccines, while in Canada, most people in this country were able to access booster doses. So this includes people working in high-risk frontline care. So my fellow nurses, physicians, allied health workers around the world, in the majority where 85% of the world's population still lives, did not have access to vaccines, while people who were low risk in Canada were being offered third and fourth booster doses. And at the same time, the costs associated with those vaccines were very disproportionately higher for those in the global south than they were for global north. And that has to do with the privilege that high income rich countries had in negotiating pre-purchase agreements and securing doses of vaccine for their own populations first. So it was in that context that we started asking questions. And while we started doing this work around understanding Canada's policy trajectory as it related to the pandemic, and vaccine equity, the proposal for a new pandemic treaty emerged. And so we shifted our attention a little bit to think about what could we do in learning from this trajectory to understand what our obligations are to others, especially high-income countries. What are our obligations to others in the world? And what could an equity-centered pandemic instrument look like? What should it look like? How could we continue to learn from the process as it unfolded? And so we applied and received status as a designated stakeholder on the intergovernmental negotiating body, and so have also participated as best we could in those proceedings. Granted, it's usually a night shift for me because it's Geneva time zone and I live in British Columbia. So when we join, it's often by Zoom and in the middle of the night. So here's a bit about our study. We've done some knowledge synthesis. We've done a lot of policy mapping and a worldview analysis, which will soon be published. We've contributed to the IMB proceedings. We've done a progressive equity analysis of the IMB texts. And we've offered interventions to try and offer very specific and targeted strategies to address some of the language concerns about that text, and have tried to understand, really using some deliberative dialogue and thinking very systematically about how equity can be advanced or held back, about what we learn from all of this. So these are just very briefly, I won't go into these, but they're both articles that talk about our analytical approach and the theoretical foundations of what we're doing. And so this is our systematic equity action analysis and a very sort of integrated approach to deliberative dialogue analysis is what guides our work. And these are just a few grounding assumptions, just to be clear about when I'm talking about equity and inequity and how that informs our analysis. So we think about health equity as an aspirational ideal, a place where all people, regardless of social or geographic location, would be able to live with dignity and to reach their potential. And systematic inequities are visible, measurable outcomes and disparities in health that are human-caused, unfair, actionable, and avoidable, and therefore are everybody's responsibility. We also assume that there are known causes to these inequities, and those known causes have to do with the distribution of resources and power. And that inequities, although equity might be an aspirational ideal, the experience of equity or inequity is very real and manifests in people's day-to-day lives. So these are some of the assumptions underpinning our work. So what did we find in our policy analysis about Canada's portrayal of itself in the world, or the worldview? If anyone wants to talk more about worldview analysis, I'm happy to go into that during breaks. But Canada generally portrayed itself in the world as a very generous, equity-minded protector of human rights that was one of the most generous contributors to the COVAX facility, that really was celebratory for its role on the global stage. It did this without much apology. Most of the policy updates or announcements from the government focused on the importance of protecting the economy, that was the solution. almost every time there was a statement of equity, there was a solution offered, and it all came back down to protecting the economy at all costs. So that was the yay me kind of celebratory public portrayal that Canada advanced. And if we dig down a little bit deeper at the kinds of narratives underpinning all of the policy actions that were actually taken, what we actually see was this high level of coherence with a particular set of policies that was very incoherent with the rhetoric. So we didn't walk our talk as well as we protected capitalism, we protected a sense of nationalism, extended double standards with our own nationalistic interests and our behavior on the global stage, and really from a critical our critical analysis, really this advanced a very neo-colonial approach to our policy trajectory. This is just, we have open access examples of some of our recommendations on how to integrate equity considerations in various iterations of the pandemic treaty that did a textual analysis, giving line by line suggestions on how that language could be improved. And these were submitted both to the IMB and to our negotiators within the Government of Canada. And in the end, we sort of have three primary messages that we keep coming to, regardless of whether it's in our dialogue process or our textual analysis of the IMB proceedings, is that the operationalization of stated ideals is really how equity gets advanced or entrenched, or sort of, my favorite word lately is it's kind of like a gaslighty state of saying how much we care about advancing human rights and equity, when actually we do a lot of things that just are in absolute discordance with that. And so we need to align our intentions with proposals, and there's very specific things we can do to make that possible. And really that what holds us back is often our ideas of what's possible. And so I would also argue that ideas and notions of, as we heard earlier, scarcity, notions of, I think I have this on another slide. Oh, I didn't put it. It's on the last slide. I'll come back to that. I'll just skip to it. Yeah, here it is. Notions of charity, otherness, how much we rely on a vague notion of others, and especially ideas about what we're entitled to in Canada versus our awareness of the impacts of our behavior in the world. Avoiding that and being very distracted from it, being very disconnected from it, allows a lot of policy rhetoric or policy action to go in direct conflict with our, sorry, I've lost my slide there. Can you make it go back? Allows a lot of inequitable policy action to proceed. And I think this rests on a lot of apathy and overwhelm, a lot of disengagement from the Canadian public, and a lack of awareness, even from within our own health settings. So there's a big, Lisa and I were talking about this a minute ago. There's such an EDI, an equity, diversity, and inclusion bandwagon that everyone sort of thinks they understand equity right now. And I have a lot of colleagues who are trying to do good things and say, you know, they have a lot of good sounding words. And then those good sounding words fall apart from extremely linear, reductionistic, finding the lowest common denominator, and then mostly just saying it's not possible. And I think this is the thing that frustrates me the most in my participation in the IMB proceedings and in talking with other colleagues is this idea that, well, we can only do so much, and we sort of supersede and let go of any possibility of protecting health through this treaty or through international health governance tables, because the trade tables are so powerful that we just kind of give up and we say, well, we can't do anything about it. That all of this was just, these are just a bunch of ideas that humans around a table made up one day, and humans around tables could actually change. And so that is what I will pause with.
Okay. Thank you very much for those excellent presentations. So we'll have a few minutes for each of our speakers to respond. Maybe we'll start with Dr. Nickerson, and the floor is yours.
I worked in the hospital for a long time, so I very around thanks very much.
No. You want this one?
Sure, I'm going to do this. Thanks. So, look, I mean, I think that we're by and large kind of all on the same page on this one, unfortunately or unfortunately, I guess. So there, I'll just pick up on a couple of things that both of you said, and actually there's something that I think is relatively common between them, and Dr. Plamondon sort of finished on this point of, you know, the isms, right? The nationalism, the capitalism, and so on. So a lot of my life focuses on access to medicines and medical countermeasures development and so on. And for better or for worse, I would say probably for worse, the world has decided to outsource the development, manufacturing, and distribution of vaccines, medicines, and diagnostic tests to the private sector. So with very few exceptions, the vaccines that you use, the medicines that you take, and so on are developed by profit-motivated companies. And for some things that works, sustains a market, things are available at, you know, reasonable prices and so on, and more or less universally available, you know, things like Tylenol or paracetamol and so on. For many, many things, there is a fatal imbalance in access that the world has decided is sort of the collateral damage of having a, you know, profit-motivated pharmaceutical industry that produces new life-saving medicines and is allowed to price them at whatever they want and distribute them wherever they want and however they want, which is basically what happened during the pandemic. There was very clearly additional production capacity that could have been leveraged for multiple types of vaccines that have subsequently come onto the market that was not used, that was restricted from being used because of intellectual property rights and an absence of technology transfer, and so on. But those problems that are fundamental to it are not actually unique to the COVID pandemic. We see this all of the time. Jeremy, you touched on it as well around the issue of sustainable production. And you know, there's another challenge here, which is that not all medicines that we need are actually encumbered by intellectual property rights and you know, an absence of tech transfer. In fact, there are a number of very old medicines that we need access to that are not sustainably produced because market forces simply don't make that very profitable. I mentioned this, you know, we're responding to a diphtheria outbreak right now. There are basically two companies on the planet that currently produce diphtheria antitoxin, which is the treatment for diphtheria. Why is that? Because there are not very many cases of diphtheria in a normal year. The last time that we had multiple simultaneous outbreaks was in 2017 in Bangladesh, in Cox's Bazar, in the Rohingya refugee camps, and in Yemen and in Venezuela. We are now responding in multiple countries. MSF and the World Health Organization are currently buying 100% of the produced doses of diphtheria antitoxin that are being produced on a monthly basis on the planet, and it is not enough. And so why is that? Diphtheria antitoxin is expensive to make. It's actually an old, very, very, very old product. You make it in horses. You have to, you know, basically infect horses with diphtheria, and then it's an equine-derived thing. It's costly, it's expensive, and there's not very many cases, so nobody actually produces it. So occasionally we run into problems where we need a bunch of it, and nobody makes it. That is actually the case in Canada. It's imported by a Brazilian company. It's, you know, quite cumbersome. So, like, these are the kinds of things where the world has decided to rest on one of the isms here of capitalism, as sort of the market forces, I guess, that are going to shape a lot of the development and distribution of medical countermeasures like vaccines and therapeutics for basically every healthcare product that we need access to. And for some things that works reasonably well. There are a number of different markets that actually function pretty well. Measles vaccines and a few other things work pretty well. But for many other things, we have decided to just live with, as I say, this fatal imbalance. And this is where in the pandemic, I think we ran into this real confrontation of, one, this was a poor public health choice, clearly, where we allowed some parts of the global population to have access to 2, 3, however many vaccines, prior to some countries having access to even 1. So as a public health strategy, that was a poor choice. In Canada, the mantra here was first dose is fast. I don't think that anybody ever received a clear explanation for why that was an appropriate domestic public health strategy in rich countries, but an inappropriate global public health strategy, despite the fact that that's exactly what we did. But fundamentally, this was a confrontation of values and ethics. I do not accept that this fatal imbalance in access should persist. There's no reason for it to persist. In fact, I would argue that there are, market and profit based reasons why it doesn't have to exist. We've allowed monopolies to exist for many of these things. But how we actually fundamentally address this through complex bodies of international law, I think remains obviously the challenge of the day, because we're dealing with multiple intersecting treaties, bodies of public international law and so on. But yeah, just to say, I think that all three of us are sort of circling around some of the same issues. I think that we should all be concerned and to a degree skeptical that pandemic instrument is going to address these concerns. I don't think that it will. For some of these problems, the solutions are frankly a pretty massive rewrite of the way that we have been developing and distributing medicines and so on. And I think we need to have that conversation because we live in a world of market failures for many infectious diseases. But I think that we should be concerned, as Jeremy mentioned, that some of the language is pushing us towards frankly a lowest common kind of denominator and may actually exacerbate some of these problems that we're seeing.
Thank you. Professor DeVere.
I think I'll just
You'll just wait.
yeah,
Yeah. Okay. All right.
Yeah, maybe just to build on this a little bit, the extreme sort of flaws of logic and double standards that are used. So Canadians in general, with some groups protested, but generally there was a high degree of compliance and acceptance of a notion that there would be some limitations on individual behaviors. I won't say not all of them are rights, like wearing a mask or showing proof of vaccine to enter a public non-essential place of service like a restaurant. These were things that generally there was a high degree of acceptance that this was something that each individual could do to take a step during the pandemic, like to embrace their agency and an act of care for their immediate family, for others, and to generally not expose others. There's some debate, there's some groups that protested against this, but generally Canadians overall were okay with that. But that same logic didn't extend as soon as it came to public awareness of how our actions might affect others in the world. There wasn't the same kind of public dialogue about that. There was almost a complete ignorance and an assumption that we didn't have to think about this as a global issue. And the same kinds of flaws of logic in terms of a very imbalanced distribution of vaccines globally. So in terms of, yes, it made sense to have priority populations vaccinated first in Canada, of course. We can deal with that. But when it came to internationally, we were very okay with waiting until everybody in Canada first had access to everything that we might want, to to the degree of a sort of brand preference for vaccines, which is very bizarre. I used to work in public health as a nurse giving vaccines to people. No one ever asked before, what manufacturer is this vaccine from? It was just a vaccine. I'm getting my vaccine for measles, mumps, rubella. Nobody knew. The general public didn't have a demand for a particular kind, but it became kind of trendy to, and I still heard, even recently, I had an aunt who was telling me about whether, is it okay that I've had like 2 Moderna doses and now I've got a Pfizer one? And like people are caring about their vaccine brands like they do their shoes or purses. So we had these bizarre notions of what we were entitled to. And we had all of this sort of really relies on a very dehumanizing look at the world that is extremely wrapped up in a sense of not caring for others and for particular lives just not being worth our attention. And the thing is that at some moment in the world, the 85% of the world's population that doesn't live in this weird space where that rhetoric is even possible might just push back. And so one of the things I heard during the IMB negotiations, this like very polarized, clear north-south divide. Part of it has been that the global south has a lot to gain and the global north has little to lose. I've heard that a lot, that's part of what allows these sort of extremely polarized and divisive and allows certain voices to be amplified. Like the pharmaceutical industry has a loud voice at these tables, for example. But actually, I think the global north has far more to lose. It is a misnomer to think that there isn't much to lose because our behaviors hurt our own it extended the length of the pandemic. It allowed new variants to arise, and just the willful blindness to the sort of realities of what makes us vulnerable or what makes us connected in the world are really hurting us and holding us back. And it's not just a pandemic or a pandemic treaty issue. This is about our climate, it's about our earth, it's about our sustainable futures, period. So I think all of it we would do well to kind of question these and unsettle some of these flaws of logic that really aren't very helpful.
Thank you very much. All right, so we have a few minutes for questions. So I will open the floor. All right, there's the first question there.
So, thank you for a very interesting panel. And this is really very cutting edge. I wanted to ask 2 questions, one for Jason and another for Jeremy. And Jason, I understand your reluctance, lack of interest that this treaty would move forward. But I see from your intervention that it would appear that politics rather than science is likely to determine when we can make a call of public health emergency of international concern. Because you were very right to say that so many diseases are already being bypassed in this negotiation. And then that makes me ask you, or maybe invite you to reflect whether, would you rather that we move ahead with reviewing the international health regulations rather than waste bloody time talking about a pandemic treaty that is already hijacked? And that's for you. If you want to, I can add my question to Jeremy so that I'll shut up, okay? So Jeremy, the proposal you have shared for ABS that is modeled after the plant treaty, the dynamic of the negotiation appears to be is the one supported by the African group, which is called, quote and unquote, Friends of Equity. But most developing countries are highly invested in the global data banks all over the world. They still want those to be operational, and they're not willing to really yield to the WHO the custody of those databases, which could only make it possible to replicate the FAO scheme in the WHO framework. So that is still contentious. I don't know whether you picked that idea that it is not a done deal yet. Thank you.
Thank you.
Okay, so I'm skeptical of many things. Pandemic instrument is one of them. But no, look, I think that clearly the world is alive to the fact that things did not go well during the pandemic on multiple fronts, multiple things, you know, from equity to, you know, trade disruptions and so on. And, you know, is it right to place the emphasis on reviewing the IHRs versus the pandemic treaty and so on? I mean, the reality is both of these things are happening in real time, and I think that there's opportunities within both of them. I'm not sure, like, just coming back again to like the sort of neglected crises and neglected diseases and medical countermeasures development and so on. I'm not really convinced that either of these processes are going to yield significant improvements for many of the most complex kinds of crises on the planet. I don't think that they're designed to achieve that either. And from a scientific perspective, which is actually where I think governments, you know, need to be connecting these discussions to things like domestic innovation policy. I think that we've got a massive blind spot, quite frankly, in the way that, you know, every society more or less is prioritizing the kinds of science, the kind of innovation policies, the kinds of research and development that needs to be done. I'm not sure that the world has fully woken up to how much of a risk we are about to face related to emerging infectious diseases. Some of that is, yes, clearly going to be fueled by climate change. There are very good modeling stuff. You know, there's very good modeling studies that show that over the next 40 to 50 years, we're going to have something like 15,000 different species that are going to have animals that are going to interact with each other for the first time. There's going to be more and more viral spillover. There are going to be more and more arboviruses. Things are just going to happen. And I'm really not sure that either of these processes are well equipped to address you know, the kind of investments that the world needs to be making in developing, you know, vaccines, therapeutics, even things like monitoring and surveillance of you know, emerging infectious disease outbreaks. So I think both of these processes obviously need to happen. There are you know, there's progress that can be made, but I think that if we are viewing these as you know, sort of the be all end all of how we're going to respond to future infectious disease outbreaks and pandemics, I think we stand to be disappointed.
I don't have very much to add to your response to your question, Chidi, except to note that Article 12 on access and benefit sharing seems to be the #1 priority and will be a flashpoint for negotiations going forward. I think the fundamental issue is that the relationship between Articles 9, 10, 11, and 12 is conceptually flawed. And the idea is that we're supposed to have open access to the underlying data, but openness is not enough to achieve equity. And that's difficult actually, because many people in the intellectual property space and in the data governance space have for decades been advocating for more open access as an equity enabling policy measure. But what we now see is that openness is not enough because it depends on access to the tools to take advantage of the data that's being shared and openly accessible. And so until we recognize that reality, I think that paradox is going to persist.
So I'm hoping to pick up on the point that Jeremy just raised and ask this to Katrina, because as we think about access and benefit sharing, it seems that this is something that could have had high hopes from an equity and human rights perspective. We would think that there's an obligation to provide data. We would think that there's an obligation to provide access to the resulting medicines. But when we combine them suddenly we are capitalizing on it, we're commercializing it, we're transactionalizing it. We're creating something that could have been two independent obligations that could enhance equity and turned it into a commercial transaction. And so I'm wondering, as we move forward, is the best approach to achieving equity to get rid of this idea of access and benefit sharing? Or how do we reshape it in order to create something that can be more equity enhancing to ensure that we don't make people's access to medicines dependent upon some sort of access to pathogens, because that seems fundamentally unfair and in equity disenhancing.
Yeah, I agree. It's a conflation that actually serves only very particular interests at the costs of others, right? So I do think separating them would have been better. I don't know. I haven't thought about whether in our analysis, we haven't recommended throwing it out entirely yet, but it's an interesting proposal and merits some thought. I think the thing that gets in the way often is the conflation isn't called out enough. There's an awful lot of performative pretending and like running around in circles, and then the negotiating process itself, the inequities built into that make it very difficult for a proposal like that to even come forward, because the ways it's structured really elevate and advance, even though there's this sort of procedural structures that are supposed to give everybody voice. It really doesn't give everybody the same kind of voice, and it relies on, who can send teams of, which country can send a team of 40 people to participate and join several different working groups that might be negotiating this, versus a country that has enough resources to send one person who's actually negotiating both the IHR and the IMB all at the same time, and is somehow supposed to be in like 4 rooms at one moment. So I think that the proposal has merit to really unpack where the conflations are, and to look at extending the what's written down with ways in which it would be operationalized. And we need to think through those things, because that's how the text of this instrument would be. What it will effectively do or not do is going to rest on how it's interpreted and used, especially by the power holders. And so it has to always be analyzed through that lens of how is it going to be operationalized and used to continually elevate particular interests over others, and not calling out some of those very real practical ways in which this will result in. And we can even use the example from South Africa in sharing the early sequencing and the policy reactions from it as a, here's what happened when a genomic sequence was shared early. So we know that this isn't just an imaginary, or like we're being too sensitive to think that text would be potentially harmful. So I think we have to call it out, name it, unpack it, and explore alternatives. And I like the idea of maybe suggesting that this is so problematic and so high risk for perpetuating harm that maybe we need to reimagine the whole thing. I don't know that reimagining the whole thing will happen, because they're kind of sort of rigidly in place already. And I don't know, the whole thing has been a extremely expensive busy work exercise. So I don't know that they're going to throw that out. But that's my sort of rambly thoughts. I don't know if either of you want to.